Tepotinib approved in the US, you see with ABM401, you've got the best response profile. ORR is high for treatment-naive patients. For the phase 2, will you still be able to recruit treatment-naive patients or patients who have not been exposed to a prior MET inhibitor?
So currently, U.S. patients do have options. However, the options, as you pointed out, response rate, even in the frontline CAP, Dr. Wolf reported 68. Tepotinib, I think I reported 50%. And then this ABM drug really is in par or potentially superior. As a treating physician, I feel comfortable offering as a frontline treatment in the United States. Furthermore, we all have been using MET inhibitors for a couple of years now, and we know the peripheral edema, the dense edema, is a challenge. Of course, GI toxicities for the existing approved 2 agents. This one also have the opportunity to make the patient, to make the quality of the life patient a little better. So from the physician perspective, I think both efficacy as well as side effects will put me very comfortable offering in the front line.
I was very interested in your presentation, I guess. How was the condition of a grade 3 treatment-related adverse event patient in phase 2? Is there any dosage change?
Actually, only one patient had a grade 3, yes, during the phase 2 study, and another one patient grade 3 was during the phase 1. Yeah, and fortunately, phase 2 study patient is my patient. So after suffering from the grade 3 toxicity, I reduced the dosage, actually 80 milligram to 600 milligram. Yeah, but due to the short duration of the follow-up, I'm not sure. Yes, so 600 milligram was sufficient to maintain the response. Yeah, but as I commented, we followed actually 3. The duration of median is around 5 to 6 months, so we should check the status of patient.
I'd like to give additional comment regarding the rash. Actually, when using EGFR TKI, skin rash is a very unique but common toxicity. These toxicities relate to those of the EGFR TKI, but in this trial, we did not see the skin rash as frequent as EGFR TKI. So these rashes really relate to the drug mechanism or activity. I'm not sure whether these rashes really relate to the drug activity. So actually, I have already given these drugs to many patients of mine, but all of them did not complain of skin rash at all. So it's a rather unexpected toxicity rather than the on-target or off-target toxicity.
Maybe 2 more questions. The first on co-mutation, in this case MET amplification. So many exon 14 patients also have co-amplification. There have been reports that from the geometry trial that potentially capmatinib doesn't work so well in patients who don't have co-amplification. I wonder if the panel could potentially comment on the veracity of that or real-world experience, and whether later generation MET inhibitors like ABM401 could potentially work better in that patient population.
there are two aspects. So one is co-amplification in patients with a MET exon 14 skipping mutation. So we have looked in the trial data of the geometry trial for capmatinib, but there was no correlation. So it's not a better efficacy if in addition to the MET exon 14 skipping mutation is also MET amplification. So there's no correlations. This is a first thing. The second point is MET amplification as a true driver. What do you mean? Yeah, so the efficacy was lower, definitely. It was around 40% in the first line, around 30% in the second line, but only with a really high gene copy number level of 10 and more. And this is a frequency of only around 1%. So I personally think it's a medical need to develop targeted therapies against MET amplification as a driver, in particular in the situation of resistance or after primary IO chemotherapy. We have discussed it with both companies in the meantime, but there's not much interest. So it's used off-label. In Germany, at least in my country, we use it relatively often in the off-label situation if we do NGS testing in relapse after IO chemotherapy, and we see MET amplification, a significant MET amplifications, and we use a MET inhibitor, and we see responses, of course, and a higher response rate, of course, as a standard treatment of docetaxel.
Just want to add a couple of data points. We reported about 2 years ago a 700 patient cohort with MET exon 14, combining US Garden cohort and the GenPlus China cohort. In those cohorts, we saw about 8% MET exon 14 with co-amplification. So it's not a huge patient population. In the clinical experience, I felt those patients do tend to respond a little better. Almost feels like the tumor is a little more addicted because they not only have the skipping, but amplified that particular event. So the tumor is a little more addicted. But if that will really truly translate into the big difference, I don't think we have that power sample size to distinguish. So that's that one comment. In terms of MET amplification as a de novo event, I think Dr. Wolf's earlier publication delineated really well, where when you have extremely high focal copy number change on chromosome 7, not having EGFR BRAF that's on the neighbor that's also amplified, those 10%, those 1% of the patients, they don't have KRAS co-mutation, they don't have other driver events. They are actually the driver with greater than 10 copy number when it's a focal. It's a smaller patient population. In the US, it's in the NCCN guideline. We actually can use it. So some of the physicians we do oftentimes as a second line option after those patients exposed to other systemic therapy.
So either capmatinib or tepotinib?
Yeah, so that's both, because I think you reported in the original New England Journal paper really nicely delineate less than 4, 4 to 6, 6 to 10, and greater than 10. And in the Vision trial, they have arm cohort B, and then those ctDNA copy number greater, actually similar to tissue greater than 10. We reported a year ago at ASCO, same response rate, 42%, better in the front line than the later line. I do want to say that I agree that it's a unmet need, because currently, although it's in the NCCN guideline, but a lot of people are not aware of the benefit. So I do think there is a space. 1% non-small cell lung cancer is basically half of the acute leukemia diagnosed every year. So it is a unmet need.
So, Dr. Wolf, could you comment kind of what's your first impression of the data presented?
Yeah, thank you for the question, and also thank you for the invitation, and congratulations to Evian for presenting these results. Yeah, first impression, of course, this is an effective drug. Clearly, overall response rate 75% in the first-line situation. But of course, the competitors, capmatinib and tepotinib, are also effective drugs. Otherwise, they would not have been approved. But what I, from the perspective of an oncologist who has treated really many patients with capmatinib as well as with tepotinib, is really remarkable is the toxicity profile. So the low percentage of edema, for me, was the most impressive first signal. Because remember, this patient population is not an average a trial population. So they are on average 10 years older with more comorbidities. And edema is a relevant clinical problem because there is no effective treatment of edema. So edema is really, so we use mild diuretic therapy, which we do not like in older patients. So we recommend exercising and compression stockings, but everything is unsatisfying. And edema is really an issue decreasing the quality of life of the patient. So I think it's interesting in first-line treatment for this special patient population, but of course, as already mentioned, as a combination partner in the resistance setting.
What's your, comment on this, initial data presented?
I share the enthusiasm with Dr. Wolf and the rest of the panel. I think the drug is very promising, not only offering good potential efficacy, but also mitigate the high toxicity we've seen with existing approved agents. So I'm very happy to offer those as a opportunity for my patients in the front line.
Dr. Lee, I know that both of the drug capmatinib and tepotinib are available in the U.S., right? So you might have some sort of good experience with either of the drugs. So can you just share some of your experience in the clinic with either of the drugs?
Yeah, so we use both. I think because capmatinib was FDA approved earlier, so in the U.S., the majority of the physicians actually prescribe capmatinib up front. It's a twice-a-day drug. Sometimes my older patient, they start to forget. So this IBM 401 as a daily drug definitely has also convenience to the patients as well. Tepotinib is a daily drug. However, those two drugs, both of them, like Dr. Wolf and other folks were talking about, when we first start the patient, we warn them about the potential edema. We are checking with them about their exercise, about their compression stockings. Nonetheless, oftentimes 4 to 6 months into the treatment, we start to see that very dense edema interfering with patients' life. They can't button, they can't write. There are times we start to see pleural effusion and pericardial effusion. Those could be life-threatening complications as well. So in the U.S., we use those drugs because they reduce the tumor burden, they have nice response. However, we are looking for opportunities. Can we improve upon? Can we at least make the patient on the right dose for even longer time? If that's the case, the patient probably can benefit even longer. So we are looking for new opportunities for all the patients.
Cool. Okay, so my understanding in Korea, either both of drugs, capmatinib and tepotinib, is approved, right? But not reimbursed yet.
Yes,
is that right?
both drugs are already approved in Korea, but because of financial toxicity, the Korean government cannot give any reimbursement.
So you may have some quite limited experience with either of the capmatinib or tepotinib, but if you have, can you share some of your experience with either of the drugs? If you have.
Yes, I have. Actually, I have already participated in these phase 1 and 2 study of these capmatinib and tepotinib. Actually, Dr. Wolf already mentioned that the capmatinib has with a poor safety profile, actually, as well as peripheral edema. These two experts already mentioned or point out the peripheral edema, but I think when receiving capmatinib, many patients complain of general weakness, nausea and vomiting, and decreased performance status or quality of life. Actually, compared to capmatinib, tepotinib, I think with a safer safety profile, but still tepotinib has also some toxicity, although the toxicity of tepotinib is better than that of capmatinib. So we need more safe, actually we need a safer drug in terms of safety profile or quality of life. In this regard, this avian compound might be a promising agent. Actually, in terms of efficacy, I don't think there are big difference between these three drugs, capmatinib, tepotinib, and the avian compound. But I think when giving the tyrosine kinase inhibitor or target agent, we consider the safety profile as well as efficacy profile, because many patients receive long treatment of EGFR TKI. So actually this situation is similar to EGFR TKI. In terms of EGFR TKI, osimertinib is a better safety profile compared to other EGFR TKIs, first generation or second generation. So we prefer, especially in Asia, actually osimertinib did not improve the overall survival compared to first generation or second generation EGFR TKI. But in Korea, many doctors prefer the osimertinib because of good or better safety profile. So we need agent having a safer and better safety profile.
Dr. Lee, so another Dr. Lee, another doctor, please. Can you share your own experience if you have?
Actually, Dr. Wolf and Dr. Lee and another Dr. Lee commented very well. Yeah, and actually they have a big experience. Probably I should just echo their voices. Yeah, so actually. When we treat actionable driver mutation patient, we always expecting, for example, longer follow-up duration. For example, sometimes we prescribe 3 months medication, osimertinib or alectinib or lorlatinib. But probably if we have this safety profiling of peripheral edema from the MET inhibitor, capmatinib, tepotinib, probably we can prescribe a long duration of prescription because of the concern of the safety profile, and probably a patient should visit our patient clinic on scheduled visit. So actually we are very concerned about the safety profile from the targeted therapy. So probably this will be a good opportunity to test a better safety profile. And again, we can stress the combination of the MET inhibitor, because always MET is one of the acquired return mechanism. Recently, I prescribe for ARC and MET. The patient prescribed with the crizotinib and lorlatinib. Actually, due to the crizotinib has some MET activity, so I should reduce the drug dosage. So we have a better safety profile compared crizotinib, tepotinib, and capmatinib. We are happy to combine drugs with the other targeted therapy.
One more comment. I would like to I'd like to point out the patient characteristics of patient c-MET skipping mutation. I think you already seen the patient characteristics. Actually, unlike other actionable mutation, more male patient might harbor the c-MET skipping mutation. And actually, compared to other exon mutations, the median age of diagnosis of c-MET skipping mutation is rather old, more than 70 years, whether compared to other exon mutations. Actually, in other exon mutations, the median age of diagnosis is less than 60 years, which means that we need more safer drug. Actually, elderly patients sometimes cannot tolerate well even EGFR-TKI therapy. Actually, I think you know well the EGFR tyrosine kinase inhibitor is a better drugs in terms of safety profile, but exon mutation, the patient harboring exon mutation might be whether in good performance status, but c-MET skipping mutation positive patient might be different from patient harboring other types of exon mutation.
I'm going to move on discussion point to something else. Now, everybody mentions combination, right? So combination, I believe, maybe that's the next one to pursue. But I don't know whether the more the better or the less the better, right? So I think we're kind of dilemma here. So of course, we do know not any single target agent has ever cured of the advanced metastatic disease so far, right? Then maybe the same is true with this c-MET exon 14 skipping and or amplified subset of population as well. So now the next wave of research may be, of course, combination strategy, right? So what is your position? What is your personal, opinion on the combination in this subset of population?
So it's actually exciting that we have drugs that have a different mechanism of actions now, that combination become possible and feasible. I think like a couple of weeks ago, we heard about FLAURA2 combining chemo with TKI. I think we will be hearing antibody-based combination with TKI with chemo. I do feel excited about the potential combination, and the TKI combination has always been there as well. So I do feel if we combine smartly, we probably can achieve better benefit for the patients.
I totally agree. And in addition, I think we have, regarding this combination discussion, we have to distinguish two scenarios. So combination for the MET exon 14, as you have mentioned, and the only thing is what we have to consider here is that this is a more fragile population, and if you see the toxicity data of FLAURA2, I would be a little bit skeptical for these older patients, at least if there is a pronounced comorbidity to use it together with a chemotherapy, because we are very happy now to have a MET inhibitor without these side effects. And to add one aspect to our previous discussion, seeing the trial data, I was also impressed that the permanent treatment discontinuation rate due to adverse effects is 0. So it was around 10% with tepotinib and around 10% with capmatinib, 10 to 15%. So here, as you mentioned, we need smart combinations. Maybe IO, but MET exon 14 is not immunogenic necessarily, so we have to think about. But what is definitely attractive is for the MET amplification as a resistance mechanisms in TKI therapy is a combination. And we have seen trials with the EGF receptor, TKI resistance, Savannah, Insight, and so on. It works. It's also my personal experience. I have treated a lot of patients with osimertinib and tepotinib and with capmatinib. So it has a relatively favorable toxicity profile besides already mentioned edema. So I think this is really a very an exciting perspective. Also because MET amplification is across all typical receptor tyrosine kinase is a widely spread resistance mechanism.
Well, our panels are, support of combination. Of course, I do think that's the next wave of research. But personally, I'm a kind of guy who prefers the less the better. That's my personal principle when treating my patient in the clinic. So even though I agree, the next wave of research will be combination, but is it really the best or the only approach? We may have some, split of opinions there. So now, that being said, can I ask you kind of silly or provocative questions? Please do not misunderstand. I'm not offending you. I'm just asking for discussion, okay? So, given the small, very promising data of 75% of response rate in the treatment-naive population with ABN-409, do we still need combination in the first line? Then, no. What's the goal? What's the goal of the combination to beat that 75% of objective response rate in the first line as mono? So if you would like to try combination in that setting, what's your goal? 90% response rate or what?
I think we need response rate and duration of treatment.
Yeah, of
Actually,
course.
when using ARC-TKI, we do not consider the combination at all because when using ARC-TKI, the median progression-free survival is more than 4 or 5 years. In such case, we do not want the combination of ARC inhibitor and other agent. And in addition, actually, when using the combination therapy, we have to consider the toxicity. Actually, especially for EGFR TKI or other types of TKI, when combining other agents with TKI, we might see the unexpected, very serious toxicity, pneumonitis, hepatitis, or others. In such case, the patient might lose the opportunity from the single agent efficacy at all. So when consider the combination, we have to consider the toxicity. And in addition, we also consider the convenience. Actually, TKI is an oral agent. However, immune checkpoint inhibitors or the antibody conjugate and chemotherapy is an intravenous drug, which is very inconvenient. So when consider the combination, we have to consider both toxicity and convenience as well as efficacy.
I think I'm on the other camp of aggressively combine upfront. Because, for example, the recent report of FLAURA2 demonstrated statistically significant progression-free survival in the first line, even with an excellent drug like Tagrisso. And then osimertinib, but their baseline, either combined or not, the response rate is 75 to 80%. And then our own data showed very similarly. Biologically speaking, there might be a subset of patients if you aggressively combine so that the initial tumor burden will be reduced so much that you might be avoiding certain resistant clones down the line. And then I think for me, I think it's basically style type of thing. I want to treat very aggressively upfront and then trying to derive as long as a benefit as possible.
Normally means for the majority of the drivers in lung cancers, this is exactly also my philosophy. But as already mentioned, given the special characteristics of the MET exon 14 patients, is the older age, the higher comorbidity, I'm a little bit skeptical. So with tepotinib and capmatinib, we know now that the median overall survival in the first line setting is around 2 years. 2 years, a little bit more. And so I would expect at least also these 2 years. So means that we have this older, fragile population with a very mild therapy. We have a substantial proportion of patients. They live longer than 2 years because it's a median. So, but definitely there is also a subset who might benefit. So maybe one could think, but this is more research than clinical practice.
Right.
Maybe one could think about a translational program looking for a clearance with liquid biopsy to identify such a population which might benefit from a combination. But
here we hear that our experts say that we may expect some additional benefit, better outcome with a combination, but maybe at the cost of some increased toxicity, especially given the specific, peculiar characteristics of this population, who are typically quite old population, median age 70 plus minus something, right? So compared with the other subset of driver oncogene-driven subset of lung cancer patients, they are maybe 10 plus minus years older as a median age, right? So that not putting aside, now that Dr. Liu, you just mentioned about one of the potential combination partner could be ADC, right? So that now that you're saying that, may I ask you that, coming back to the another ongoing trial, so-called Mariposa, right? So which combines ADC, amivantamab, which is a bispecific EGFR MET bispecific antibody, right? If the Mariposa starts, it could be a positive trial, maybe statistically, but I don't know whether how relevant clinically anyway, right? So if that study, turns out to be positive later on when the final data is available, what's going to be the, fate of our c-MET inhibitors? Not just ABN-401, but including tepotinib and capmatinib. They'll still be there?
So amivantamab, the EGFR MET bispecific antibody, I think we probably want to separate in the MET exon 14 space versus in the MET amplification resistance space. In the MET exon 14 space, I think there's still a huge need for TKI, especially upfront, a tolerated TKI. Older population, we need better tolerability. And then TKI offers really already excellent response if the patient can stand on the TKI long enough. For the resistance setting, I think it's a little bit different, where the Chrysalis 2, Dr. Benjamin Bassi showed that after EGFR TKI progression, this double approach could be quite efficacious in the MET high patient population. So that I think for the antibody-based approach, especially that particular agent, will be a very strong competitor against TKI-TKI combination.
There's another, rising guy called ABN-401, which seems to be quite promising, especially in terms of better tolerability. So please keep that in mind, and you're coming back home. And another question you have, please do not hesitate to come back to email or to mail, to message, whatever available. Then we are happy to address your questions. And thank you very much, all our global panels and all the attendants there. Thank you.